That was an excellent presentation by Dr. Benjamin. He's truly a leader in the field, and we're hoping that we can do more work with him over the next few years. He's terrific. So, and thank you everybody for being with us this afternoon. We have a good panel for you. We'll have the presentation from 1 to 2, and then we'll have question and answer from 2 to 2:30. Please use the chat box to put your questions in. We think this is going to be a very stimulating presentation. As you know, we do a series of papers every year, and our papers have been on Beyond Beds. This year, our papers are on the crisis services part of that. One of the papers that we did at SAMHSA's request, they wanted it turned in early. So we turned that in December. And then it was interesting because we worked very closely with Dr. McCann's Katz on this paper. And we went back and forth between Dr. McCann's Katz and the writers. The main writer was Paul Galdus. And I have to say, he was terrific. And he's a colleague of David Covington. Paul and David were great. We went back and forth, back and forth, back and forth. But in the end, I think we ended up with a really nice product. And SAMHSA decided to use that as their national guidelines for behavioral health crisis care, the best practice toolkit. So we're very proud of this. It came out the end of February. Unfortunately, then COVID hit. So I think all of you are aware of the toolkit. I think that we've been able to get that product out to all of the commissioners and your leadership. But we wanted to take the time to really, after Dr. Benjamin talking, we wanted to really hit hard what we think is a difference maker going forward in behavioral health. Now on the panel, we have Michael Hogan, David Covington, and Sonia Gaines. And I want to say a few words about all three of them. And I know that these are people that are well known, but I just want to say a few words because it's really impressive, the leadership that we have behind crisis services, the strength of the personalities, the enthusiasm, and the energy. So I think most of you know Mike Hogan. I think he served as a commissioner. I think, Mike, it's been what? It was about 40 years through half a dozen states. Dr. Hogan served as state commissioner of mental health for New York, Ohio, Connecticut, and totaled, I think, the longest, maybe second, as I think about it, one of the longest tenures in these key leadership positions. Previously, he chaired the President's New Freedom Commission on Mental Health. He was appointed as the first behavioral health representative on the board of Joint Commission. He's been a member of the National Action Alliance for Suicide Prevention since it started 2010. He served on the National Institute of Mental Health's National Advisory Mental Health Council. And this is the biggest, right? He was president of the National Association of State Mental Health Program Directors from 2003 to 2005. And he was board president of NASMHPD Research Institute 1989 to 2000. Over the last 30 years, he's been one of the most significant voices for change and a longtime friend of NASMHPD. The next panelist is David Covington, who is known globally for his leadership. David serves as the CEO and president of RI International. He's the owner of Behavioral Health Link, leads the international initiatives Crisis Now and Zero Suicide. He has served on the National Action Alliance for Suicide Prevention Executive Committee since 2010. He has served as vice chair of the National Suicide Prevention Lifeline, SAMHSA Steering Committee since it was created. He has served as the clinical division of chair for the American Association of Suicidology. He has been a force for change throughout the United States and internationally. And if you don't know David very well, take the opportunity to get to know him. I don't know anybody that has the energy that he does, the enthusiasm, the dedication. He is truly a global force. And so we're very proud to have David on our panel. Third, we have Sonia Gaines. Sonia is the commissioner from Texas. She has been there she's been at the department since 2014, when she started as the Associate Commissioner for Mental Health Coordination and spearheaded the development of the first Texas statewide behavioral health strategic plan across 23 state agencies. In 2016, she assumed the leadership responsibility for the policy and delivery of community-based services and supports for people with intellectual and developmental disabilities and behavioral health conditions. Deputy Commissioner Gaines has more than 20 years of community mental health experience. She is committed to improving the crisis services throughout Texas, and she's a spokesperson that's very valuable in leadership across the country. She has been a very valuable contributor to NASHPD. I think this is a great panel, so let me now turn it over to Mike.
Thank you, Brian. It is really a privilege and a pleasure to be with all of you now. I am really glad that you are carrying out your 24/7, 365 responsibilities, and I'm kind of glad that I'm not doing that anymore. It's in New York in the much more competent hands of Ann Sullivan. Since I left the Office of Mental Health in 2012, I've had the privilege to be able to work only on those issues that I want to work on. And you don't get to do that as commissioner, as all of you know. So it's a real pleasure. I want to speak for probably about 10 minutes just to do a setup here on this issue. So this is, to some extent, level setting. It's a summary of some of those things that are going on now, and a couple of words from experience at the end, which you can ignore before turning this over to David. We worked together, David and I, on two efforts at the National Action Alliance. The first of those was the Clinical Care Task Force that essentially was the springboard for development of zero suicide, which is something that frustrated me as long as I was trying to run these systems, and how badly we were doing in that regard. And then having done that and rested for a bit, David had this idea that it was time to get some air under the wings of crisis care, especially systematic approaches to crisis care, which led to the Crisis Task Force at the Action Alliance and the development of Crisis Now, and then the superb report that Brian mentions. And I have to say that Brian and NASHPD and others in NASHPD, Deb Penals, along with SAMHSA, are the major reason why crisis is moving now. And so, Brian and others, we really thank you for your leadership. I start this with an acknowledgement that in several of the states that I was in, I didn't do that much with crisis care, even though I knew it was a big priority. I worked on it a lot in Massachusetts, where I started my career, and then a bit in Connecticut. And the main reason for doing it in other places was not because it wasn't important. One of my mentors in a bit was Dr. Len Stein from Madison, who we all know as the developer of PACT. But Len always used to say that if you were developing a community service system from scratch, crisis care ought to be the thing you started with. And somehow that message got lost. But probably the reason I didn't work on it as consistently as I should have is that it wasn't what the system needed at that point in time or what the system was calling for. And there's a lot of stuff that comes your way that you just have to deal with, whether it's COVID or Katrina or 9/11 or Oklahoma City or opioids. When things like that happen, you've got to prioritize them. But the thing that is remarkable now, and the agenda for this meeting illustrates this, is how this critically important issue of crisis has come into focus as a real opportunity for us at this point in time. And so the confluence of significance and demand creates, I think, an urgent opportunity. The value of comprehensive approaches to crisis care, from my point of view, is now magnified by several things. The FCC's vote to make 911 basically, or 988 rather, like 911 for the brain, is significant, not just because it creates an easy to remember 3-digit number for the Lifeline, but just as important, the FCC's decision is to create a national number for mental health crisis care, not just for suicide prevention. And the calls that go to the Lifeline from people that are suicidal are a tiny fraction of the crisis calls that are made across dozens and hundreds of local and statewide lines. So the task of well fusing or well integrating in your state the responsibilities for Lifeline calls with this opportunity to create a comprehensive crisis system is a valuable and significant thing that lies ahead. The second reason why crisis is really critical is that our inpatient resources are increasingly both scarce and expensive. And we certainly shouldn't be diverting people away from inpatient care by policy fiat. We should be diverting them to alternative levels of care that can meet their needs better and cheaper without the disruption in life and the expense that crisis care solves. And that means creating alternatives. We spent a lot of time creating continued care alternatives, whether it's clinic care or PACT or supported employment or supported housing. We haven't spent as much time on acute care diversion opportunities. And so this becomes an even more important item today. And finally, going back to some of the last conversation with Dr. Benjamin, criminalization just becomes more and more intolerable. And it's time for us, quite frankly, to do something about that doesn't involve deferring the problem to cops and courts and expecting cops to fix it by better policing. The way to do that is that we've got to define having a drop-off point that is adequate to meet the needs of people brought in by CIT trained officers, a core component of mental health systems. And so the idea of crisis systems that integrate all three of these elements, the call center that is also a care traffic control center, real world crisis diversion alternatives, and especially those that offer high acuity kind of care, is really a remarkable opportunity for us today. The second dimension of this, the first thing I wanted to emphasize was how important this was. The second dimension is how hot this is. Not literally hot, pretty hot even here in Albany, but it's hot because it's happening now. The FCC's action is transformative. There's a very real chance that the Congress will pass this year a $35 million add-on to the mental health block grant that is dedicated to initial support for crisis systems. You have multiple bills in both Senate and House reinforcing these aims. And as any of you know, when the Department of Justice comes calling, Olmstead is not just about getting people out, it's about preventing people who shouldn't have to go in from being in. And so crisis care had been a component of all the major Olmstead settlements. So it's not just crisis care is not just a good thing, it's become a hot topic with real opportunities that exist for you. And I'm going to close with my top three of advice, perhaps gratuitous, because it comes from somebody who's not on the front lines anymore the way you are. But having looked at this over a 40-year career, there are three things that I would suggest. The first is to prioritize this for a little bit of your attention and for the leadership in your agency of somebody who's good, who's really good, who's going to stick with it and keep you apprised. The second thing, and I alluded to this before, is to remember that 988 and dealing with 988 is not just improving the suicide lifeline, it's moving from calls to care. And unless we take the opportunity to make the Lifeline call centers into care traffic control places that have the opportunity to develop real-time connections with people and electronic up-to-the-minute dashboards of how we're doing, we're going to miss an opportunity. So that is a particular thing that's got to be paid attention to. The third thing for me is a lesson from many years of working on this, and it's how both the lowest intensity and the highest intensity parts of crisis system are particularly valuable. In a sense, that the middle of the crisis care system is mobile crisis and crisis residential. We all know that. We tend to prioritize that. But we sometimes tend to forget two things, and that is that for a high proportion of people that are in crisis, if they can get an appointment with their therapist the next day or they can get a refill tonight, they're going to be fine. And so making access to clinic care, either through same-day access throughout our system or through the development of reliable crisis clinics, is disproportionately impactful on people in crisis. And at the other end of the continuum, I think we've come to learn now that the very high acuity, very short-term crisis alternatives, like that in Pima County, maybe the best known example, are demonstrating that they have way more bang for the buck in terms of diversion, both from the criminal justice system, when they become the place where the officers can just drop somebody off, or from the hospital, because they can provide almost a hospital level of care at a fraction of the expense, because it's going to be a very short stay. So as I said, somewhat gratuitously, those are my comments from experience. I want to turn this over to David, who's going to take us into a little bit more of a deep dive with respect to crisis.
Thank you, Mike. And I just so appreciate the ongoing leadership from all of you, and especially Brian and NASMHPD. Look, I've spent a fair amount of my career as a funder, not with states, but with health plans. And what Mike referenced of the constant fire hose of various issues makes it just continuously makes it challenging for something to give root and actually bear fruit. And NASMHPD's, Brian, what's it been now? 4 years of consecutive prioritization of crisis care services is really yielding the results that we're hoping for, laying the foundation that can look at something way, way different. Mike referenced calls to care. I'd like to use some language that I heard from Kim Williams at Vibrant Emotional Health. That's the organization that facilitates the National Suicide Prevention Lifeline. But she called it the promise of 988. So to start, let's talk about the promise of 911. Now, I'm going back a ways. Some of you are too young to remember. You can ask your grandpa what a phone book was. But there was, back in the day, there was these things called phone books, and I found the phone book from 1966 in Atlanta, Georgia. So if you had an emergency in 1966, who did you call? Well, it wasn't absolutely clear, but they did have a page in the very front of the phone book, which it said fire, and you see a blank space. It says police, and you see a blank space, and you see doctor, and it's a blank space. Now, what they wanted you to do was to look at the bottom of this page, figure out the number that you were supposed to call, write it in to this blank space, cut this page out, put it on your refrigerator, and then when you had a crisis down the street, run home to the refrigerator, look on there, pick up the phone that had that cord on it, and dial. Now, it's actually, when you look at the bottom of the page, it's not straightforward, and I'm lifting the entire thing. No, it's not missing anything. There's no explanation for why there are two numbers. Doesn't tell you which one to call. And if you live in Atlanta, but also Fulton County, it starts to get pretty confusing. Or you can live in Atlanta and be in DeKalb County, because about 10% of the city is there. So which of those four numbers are you supposed to call? It's not absolutely clear. Now, everything changed with the emergence of 911. Now, it didn't all change immediately, but it cascaded forward a set of expectations around care that were way different. We work with NASMHPD, and Stephanie Hepburn writes for us weekly an interview with an industry leader or a person with lived experience around crisis. And our very first entry over a year ago now was from Sandra Schneider, past president of the American College of Emergency Physicians. And she talked about what emergency room care was like in the 50s and 60s. 911 began us moving down a path to today's world, where we have rapid deployment of specialized care, regardless of what your issue is, so long as it's not a mental health or suicide crisis. So we're in 2020. I'm experiencing a mental health crisis. Who do I call? Well, there's still, as of today, no 911 for a mental health crisis. And if I challenged all of you right now to write down the number that you're supposed to call, it's a little harder. Mike, you might be able to do it, but Mike and I have worked together on the National Suicide Prevention Lifeline for many years. And Mike, right now, I can't dial the number. I don't know what it is. I mean, I know 1-800-273-TALK, but I don't know what TALK stands for, and that's not on this phone. So I'd have to look it up. And if something was really an emergency right now, I couldn't dial the number from the top of my head. That's the challenge that 988 is going to solve in a very significant way. So who are going to be the callers for 988? Mike referenced that there are a lot of people in crisis calling or acting, and some of them are calling the National Suicide Prevention Lifeline. Let's just delve into that in a little bit more detail for a moment. So the Lifeline started in 2005, and it built on a base of 1-800-SUICIDE, which has started 5 years earlier. So right now, we expect 2 to 2.5 million calls to come through in 2021 on the National Suicide Prevention Lifeline. About 40% of them are going to dial 1 at the beginning of that call because they're a veteran and want to speak to the Veterans Crisis Line. So that's the way that 2 to 2.5 million calls breaks down. And it's about 160, 170 crisis call centers across the country that are fielding those particular calls. The FCC has said that 988 will replace the National Suicide Prevention Lifeline. So is it going to be 2 to 2.5 million calls who ultimately will be dialing through a 988? No, that's not the answer. Because people in crisis are going to, right now, their sheet of paper on their refrigerator that came from the phone book from all of those various numbers, and they've written down a number. It might be the Lifeline, but it's usually not. It's usually a local, county, or state crisis line. We believe, and we don't have firm data on this, but the best we can tell, it's more than 16 million calls a year that come through in total, 85% of whom are coming through on the local, county, and state crisis lines. So I live here in Phoenix in Maricopa County, one of the largest counties in the United States in terms of population. We get about 24,000, 26,000 calls a year that come through on the National Suicide Prevention Lifeline. But well over 220,000 calls a year come through on the local county crisis line, which is funded through health plans, which in turn report to the health services and the Arizona Medicaid Authority. So it's about 10% or less of our call volume is currently coming through on the National Suicide Prevention Lifeline. All of those calls are obviously people in crisis in Phoenix, Arizona who are calling through. But they don't represent everyone in crisis. The best we can tell, of the 5,000 plus emergency departments across the country, 7 to 9 million visits are happening a year for people in mental health, substance use, or suicidal crisis. Some of them have not called anywhere. They thought about 911, but they didn't want a law enforcement response, and so they went to the emergency department directly. It's another set of volume that, if there were an easy to remember number, we would be tapping into. And then finally, there's 911. The best we can tell, and there's no data available to this, but the Bureau of Justice Assistance reported to those of us on the ISMIC a couple of years ago now, that about 10% of law enforcement calls are mental health, substance use, or suicidal crisis. Those calls take about twice as long for law enforcement to administer. And so the best guess we have is that of those 250 million calls a year that go to 911, a rough ballpark estimate would be about 10% of them are related to mental health, suicide prevention, or substance use. Now think about 2020. You know, Brian, Mike, we were all talking about this for several years going now, but 2020, the two dominant issues that have been coming out have been the surge on hospitals related to COVID-19 and the discussions of empowering law enforcement to do their core mission, however you want to frame that. These are the groups, and when you put that together, there's certainly duplication. There are people who call the 911, get coordinated with the local crisis line, and then land up in the emergency department. So you can't just add these together. But our best estimate is 35 to as many as 40 million contacts a year are for those individuals in pretty significant crisis, to the point that law enforcement, emergency departments, or a crisis line are involved. Now, 988 begins to go forward. So let's talk about what we know and what we don't know. The FCC, after Orrin Hatch put forth this legislation over 3 years ago now from Utah, it went to Congress, was signed by President Trump. The FCC then took recommendations from the Veterans Administration and SAMHSA, and now we have legislation before the House that's already passed the Senate that would discuss how to fund this service. But the FCC, just as of a couple of weeks ago now, has put forth a timeline, and we will have the first calls answered in the United States on 988 no later than July of 2022. So we've got a 2-year timeline that's running now. It's going to happen. Telecom industry said, look, we can only cover about 98% of the country by July of 2022. And those of us who were engaged in that conversation said, hooray, that's not a reason to put off the timeline. It's a reason to move forward and then begin to close that final 2% after we get to the main bulk of the country. Now, here's the questions that aren't known. How does this get supported and funded? So let's talk a little bit more about what we expect to happen. The simplicity of 988 for mental health crisis and suicide hotline. If you look back at the marketing of the National Suicide Prevention Lifeline over the course of the last 15 years, it is exactly that, a National Suicide Prevention Lifeline. We will now see for the first time a merging of mental health crisis. From the beginning of the legislation, Orrin Hatch was clear that this would not just be a suicide hotline, but your mental health crisis line. And again, making this much more accessible and ready. So who might call that line? Well, first off, those 2 to 2.5 million callers who are currently calling the National Suicide Prevention Lifeline, they will certainly be attempting to now access 988, as that number ultimately will be phased out. And we've looked at numbers over the course of time that have been phased out. I referenced the Atlanta phone book in 1966. That was the same year the Atlanta crisis line started. And that line was taken over by the new number that would ultimately become the Georgia Crisis and Access Line in 2002. It took years for people to stop calling that old number, even without any promotion whatsoever. Again, in those days, people did have things on their fridge, and it was a little hard to extinguish, and people gradually sort of moved across. I think we're going to see a much faster uptake on 988 because of the social media world that we live in today and the way that we work with telephony. So not only are Lifeline calls going to migrate to 988, but 988 is also going to cannibalize a lot of those local, county, and state crisis lines. Now, that may not seem like much. In some states, in Georgia, the Georgia Crisis and Access Line answers both what is now the National Suicide Prevention Lifeline and the Georgia Crisis and Access Line. So someone in Atlanta calling through is going to get the same organization regardless of the two. But in many other states, as I referenced here, the organization that answers the Lifeline first in Arizona is different from the organization that answers those 220,000 local county crisis calls. Texas is similar in that there's an organization called Avail that answers a very significant portion of crisis calls throughout Texas, but is not one of the Lifeline centers, one of, I believe, 4 Lifeline centers there. So 988 is going to begin to, because of its simplicity and the promotion of it, is going to begin to eat into those. But we also anticipate it's going to begin to be the go-to point for people that are currently calling 911 because they can't think of, they don't know what that local crisis line is, and others who don't call anyone because of concerns about a law enforcement response and go to the hospital emergency department directly. Over the course, just as we've seen with 911, over the course of the next decades, 988 will eat up all of this, and it will be the go-to point for people on their worst day. Now, let's look back just to give us some sense. This is the growth of the Lifeline volume over the course of the last 15 years. And on average, it's been about 15% up every year. Now, it also, we had a migration from 1-800-SUICIDE, which was the national line when Lifeline started in 2005. In 2010, you can see the sub-network of the Veterans Crisis Line was started, and that began to grow and move forward as well. Now, just to reflect on the differences in funding right now, the House is reflecting on legislation that would put forth a cell phone tax capability similar to the way that we fund 911 in order to power 988 as we go forward. Today, there's about 15 million plus that comes from the federal government to the Lifeline administration, but very, very little. Most of the centers in the national network receive an extraordinarily small annual stipend of a couple of $1,000s. The actual bulk of the National Suicide Prevention Lifeline activity in the crisis call centers is leveraged through your local, county, and state resources. It's not coming from the federal government. Now, as the Veterans Crisis Line grew in 2010, it began to receive a lot of focus from Congress and from the media. And there was a number of legislative acts. The Joshua Omvig legislation about suicide prevention was an additional focus that caused some scrutiny. And we saw the media really begin to look at the performance of the Veterans Crisis Line in 2015, 2016. And today, there's over $100 million that comes from the VA to fund the operations of the Veterans Crisis Line. So if you call the Lifeline and you dial 1, that's a fully funded service with the performance that you would expect, et cetera. If you don't dial 1, there's really only a leveraging of local, county, and state resources, which has worked when 5, 10%, 15% of your volume in a state is coming through on the Lifeline. But let's just reflect on what may happen as we begin to move forward into a 988 world. Again, imagine that the first calls are answered in July of 2022. That's the timeline that the FCC has now put forward. Regardless of what Congress does or what your local legislatures do, that we expect that train has now left, is moving toward the opening, and we'll move forward. 2021, we've got our best look as what those 35 to 40 million contacts look like. Now you can see it's almost 50 million on this, but there's clearly duplication. There are people who they call 911 and land up in the emergency department. They call the local crisis line and get coordinated with 911. So there are duplicates that happen here. But the green represents the Lifeline calls, that 2.5 million calls that are answered on an annual basis. The mustard yellow color are your local county crisis lines. The blue are 911 calls that are mental health, substance use, or suicide prevention, and the red are emergency department. So we're just cascading forward over the next 8 years. And look, this is guesswork at best. But what we've done is modeled based upon looking at the uptick on prior new lines that have gone nationally, looked at the migration from numbers that have been retired, and also reflected on this is a much different world in social media, and you've also got a much simpler number that is going to be readily accessible to folks. I don't know that it's even a overly audacious view that 8 years from now we could have 20 million plus calls on 988. If that were the case, you could see that it still wouldn't be the dominant way that people get into mental health crisis. They'd still be going to 911, emergency departments, and local crisis lines more. That actually seems unlikely, but I've tried to be a middle of the road here on a view of what could happen as we go forward. But again, this is going to be a new environment for all of us. Just looking back over the last 10 years and the way organizations have marketed for a crisis in the United States, I think it's probably a safe bet that you'll see this organically rise up, that people put forth two numbers as the most important in the United States: 911 for medical emergency or immediate danger, and 988 for mental health crisis and suicide hotline. That's what's going to drive all of this. So, the promise of 988, though, is not just calls, as Mike said earlier, but care. And the SAMHSA guidelines, and so appreciate the Assistant Secretary McCants-Katz and Dr. Hepburn working collaboratively to drive this effort forward that again, many people were involved with. Anita Everett was the first one that I heard put forth Crisis Now in this way. You've got to have someone readily available to talk to, which we have through 911, poison control, and a host of readily accessible numbers for professionals who can triage out and resolve many cases. But when that's not sufficient, then you need someone who can come to you. And we have that through, again, through our fire system, through our EMS system, through ambulances and law enforcement. And then sometimes that's not sufficient, and you've got to have some place to go for maybe it's a few hours, maybe it's overnight, maybe it's for a few days. We have all of that on the medical emergency side, and 988 begins to cascade forth our expectations around mental health crisis. So what the SAMHSA guidelines do is lay out some fundamental requirements and also give you an eye to best practice, how we raise the bar if you want to be in full alignment. And it looks at those three primary core fundamental building blocks: a crisis call hub, where crisis call, text, and chat. It's available 24/7. There's clinical oversight, assessment of suicide risk, engagement of mobile teams and facility connections. Think health information exchange meets your crisis call center with text, chat, and call capabilities. Raising the bar begins to look at what Mike was referencing in terms of care traffic control. It's using caller ID. It's based upon where the individual is actually located. GPS-enabled mobile crisis team dispatch. There's electronic bed registry engagement. Again, Ted Letterman has been working a lot on this project. There's electronic scheduling. So the ubiquitous electronic tools that we see out there changing every single industry are now brought into the crisis call hub under the best practice approach. And that begins to be the orchestration of ensuring people don't fall through the cracks. And we've got the data to drive the next steps of this. Mike referenced mobile crisis teams. Back years and years ago, Dr. John Draper and I were looking at the differences in practice across crisis call centers in activating law enforcement. So at the time, this was over 10 years ago, Georgia did not yet have mobile crisis in every county. And we just evaluated what happened. Same call center staff, but they had mobile crisis available versus they didn't have it available. What we found is those very same staff were 4 times as likely to ask the individual or their family to take them to the hospital emergency department, and 5 times more likely to activate law enforcement to their home or apartment or street if mobile crisis wasn't available. So this is an extraordinarily powerful service, cost-effective, dramatically reduces the engagement of law enforcement and hospitals. And we're talking about teams, they're community-based, there's an engagement of clinical response. And in your raising the bar scenario, we've got peers on the team. They're engaging law enforcement as a last resort. It's actually very few cases where, because of the presence of prior violence or a known weapon, et cetera, that we're activating law enforcement in partnership with these teams. Again, the primary goal here is in the current system in the United States, regardless of your crisis continuum, you know it's a crisis now system if you're dramatically reducing visits to the hospital, and you know you've got a more traditional approach if everyone still has to go to the local hospital for a medical clearance before they can receive other care. And what does that other care look like? Well, immediate alternatives to psychiatric inpatient, 24-hour care, call them crisis receiving facilities, if you will, accept all referrals. There's no default to the emergency department first, and they have the onboard medical and clinical staffing required for that level of acuity. The best practice of raising the bar scenario includes a dedicated area for first responders where they can come, drop the individual off, and be back on the street in a few minutes. We're actually working with the state of California now in multiple counties going through a months-long Crisis Now Academy where they're going through again, how do you develop these fundamental building blocks? States like Arizona, which have built the vast majority of this approach, have been doing that for many, many years and are now this year taking steps forward to build a little bit more. So as you begin to do this, it does take some time, but all of these components make an impact. And 988 just lays a different groundwork altogether. Tom Betlock, who was the Medicaid director here in Arizona for 9 years, helped us to think through what are the issues that states should be looking at as you look to 988. And he put forth this, again, these issues of simplification, specialization, and the new expectations that 988 will come forward with. And that's going to lean into how do we begin to think through the design, operations, and financing of that system. So at that point, I'm going to turn it over to Sonia Gaines. Again, Brian referenced up front, but she leads IDD and behavioral health at the Texas Health and Human Services.
Thank you so much, David. I appreciate it. And Brian, thank you for creating this wonderful platform for us to be able to talk about crisis services and what might be available on a national basis. And David, I wanted to take a minute to thank you and the National Lifeline for your support here in Texas. We've been able to, add some resources and some additional supports on within our existing call center infrastructure that has been tremendous in terms of allowing us to meet the needs in Texas. So thank you so much for that. I'm going to just briefly highlight some of the crisis service array that we have here in Texas. And I want to say in this COVID environment, I've been so grateful that we do have a tremendous continuum of care when it comes to crisis services. That infrastructure really has been a tremendous safety net during COVID-19. I've been amazed at how that infrastructure has really played a tremendous part. Now, I don't have any fancy slides, so you're going to be, just hearing directly from me. And I certainly can follow up with some information. We have a crisis services guide that some of you might be interested in. So I'll be glad to provide that later on. Just to give you a little background, I want you to know, I know when I was introduced, Brian talked about in Texas, we developed one of the first statewide behavioral health strategic plans that encompass 23 state agencies. And that plan has actually been paramount in terms of us, looking at what type of service delivery system we need, where are some of the gaps in terms of our service delivery system. We did, all these different surveys, got a lot of feedback from a lot of different people. And the number one thing that was identified was appropriate access to services when people need those services. We also know that when people get services at the time that they need it, that they're less likely to end up in ERs and hospitals and sometimes in our jails. And so one of the things I'm very, very grateful for, back in 2007, our legislature made a decision that we were going to grow our infrastructure when it comes to crisis services. Previous to that, most of our local mental health authorities had, call centers, 24-hour call centers, but there were a number of other things that were considered best practices that we did not have. Things such as mobile outreach teams and crisis stabilization units. And so our legislature made an investment of over $80 million back in 2007 that resulted in our 39 local mental health authorities all having some basic crisis service arrays. As I said, that have been very instrumental in providing tremendous support across our state. So I'm going to briefly outline what some of those are, and in the interest of time, I won't be able to go into a lot of detail, but again, very glad to provide some follow-up. The first thing is our 24-hour crisis hotlines, which a lot of states have those. These are, again, manned by our local mental health authorities. They're manned 24 hours a day, 7 days a week. And that means that a live person answers the phone all the time. They don't get a recording, or it's not limited in terms of time. Last year, our hotlines answered close to 100,000 calls. And this is an infrastructure that we now have in place, again, that represents every single one of our local mental health authorities that also provide outpatient services for individuals that have serious and persistent mental illness. This is also the place that our Lifeline lives through some of our urban local mental health authorities. And I want to tell you, during COVID, we were very quickly able to stand up a support line through one of our local mental health authorities that has actually been a support line available statewide. And through that COVID support line, again, people have had access 24 hours a day, 7 days a week to be able to address some of their, concerns around COVID, whether that be depression or anxiety, or simply being referred to appropriate resources. We've also used those hotlines in response to disasters. We've dealt with a lot of disasters as well as criminal events here in Texas. So things like Hurricane Harvey, the Hurricane Katrina, and most recently the El Paso shootings. Those call center infrastructures were paramount in terms of providing community support across the state. The next thing I want to mention are our mobile crisis outreach teams. These teams provide face-to-face help and support to individuals that call through our call centers. What we call an MCOT, they provide immediate response at the location where the crisis is actually occurring. And we have found that to be very, very helpful, not to require the individual to go to a certain location, but actually to go to them. And the MCOT, again, is available 24 hours a day, 7 days a week to respond to people in their homes and schools, on the street, at a clinic. And the mobile crisis outreach team also work with emergency response groups as well. We have seen, as was mentioned earlier, a dramatic decrease in individuals having to go to jails or to inpatient services or to ERs as a result of using the mobile crisis outreach teams. When calls come in, those calls are actually triaged. So we don't go out on every single call that comes into a call center, but determine which ones are most appropriate for the mobile crisis teams to respond to. Another aspect of the mobile crisis outreach team, and most recently, we've added some pilots in response to the opioid epidemic that we basically have added licensed chemical dependency counselors, and we're seeing tremendous impact as a result of adding those types of folks on the team. Some other types of services that we have, facility-based services, include things like crisis respite. Our crisis respite programs provide short-term community-based crisis care for individuals who have low risk of harm to themselves or others. We also have crisis residential programs that allow individuals to be served for 14 days or short-term stays. And those resources have been tremendous in terms of individuals that are actually transitioning, sometimes transitioning from hospitals or jail. Now they have a place to go in terms of a step-down resource. In addition to respite, we also have crisis stabilization units and also rapid stabilization units that have also been very, very helpful in terms of responding to community crisis. One of the other things I want to mention, we have a number of partnerships with mental health deputies. With our mental health deputy officers are specially trained in crisis intervention through the Texas Commission on Law Enforcement, who work collaboratively with our community and the crisis response teams through our local mental health authorities. And just to give you a little bit of a snapshot, we have 39 of our Texas counties have at least one state-funded mental health deputy program. And again, those programs have been very, very successful. One of our center executives made a statement. He said that the mental health deputies are the greatest intervention since telehealth in meeting with their peers and the Health and Human Services staff. The mental health deputies cost approximately $118,000 annually, but we've determined if they divert 48 individuals in a year's time, that cost becomes neutral. And what we're finding in our data is they typically actually exceed that number quite substantially in a year's time. The other types of programs that we have that play a huge role in our crisis diversion services are a number of programs that our legislature has invested in over the past 4 years. And these are grant-funded programs that have been very, very successful. So in addition to our infrastructure that we already have, there's about $100 million worth of grant services that we also have put on the ground. And those services, again, in the interest of time, I'm not able to talk about all of them, But one of the things I think, Brian, you were talking about earlier is partnering with 911. There's an incredible program that exists in the Houston area, which is one of our largest catchment areas. And they have a 911 program that they actually have staff that are partnered up in the 911 office. So when a call comes in, they actually know, the dispatcher can determine that if it's a mental health call. And instead of the police intervening, we actually have the mental health staff that are intervening. And then we have places where people can go. Instead of going to an ER, those individuals can be taken to one of the diversion locations. So, for example, in Houston, there is a drop-in diversion location that is staffed. Again, 24 hours a day. There's a residential component there, and they actively work with people to help get them stabilized. And I would agree with something that David said. Having alternatives for people to go to is really, really important. Not just to divert them, but, have some place where you can work with people and help them get back on their feet. So we have, several programs that fall under that, the grant funded initiatives that, again, they're just too numerous to talk about, but some of those also include outpatient competency restoration, jail-based competency restoration, re-entry programs. We also have assertive community treatment programs that are tied, as well as interdisciplinary rapid response teams as well. So that just gives you a very high level overview of some of those resources that exist. Again, I don't know what we would have done without those resources, particularly being in the midst of the pandemic. They have been just, very incredible to have those services available. So I'll turn it back over to Brian.
Thank you, Sonia. Yeah, excellent presentation by all three. So just to get it started, what has been the impact of COVID-19 on your perspective regarding crisis services? What has happened to reinforce some of your thoughts or to change your thoughts regarding best practices for crisis services? And Sonia, maybe we can start with you.
Sure. Again, I would just, the thing that comes to mind to me is one about having those services available before the crisis hits. That we are very grateful that this infrastructure was already in place, and it wasn't just that the infrastructure was in place, but our community was well aware of those resources and where to go if they needed help. And so as I look at our statistics, even during COVID, our numbers have pretty much stayed stable in terms of the calls that we receive through, the different call centers that we have. But the other thing that we were able to do with our crisis services is to pivot during COVID and do more virtual visits. And because we had that technology already in place, that has been very, very successful with being able to engage people and kind of, continue to provide the necessary services to keep people in the community versus going to those more expensive levels of care. So I would definitely say having that infrastructure already available has been a tremendous benefit for us in Texas.
And Sonia, you mentioned technology. Was that the technology for your mobile crisis or at some other place in the system?
So I would say that from a technology standpoint, we had transitioned a number of our service delivery systems to be more mobile. And having the mobile crisis team, as you can well imagine, we have So we have 254 counties in Texas. 70% of them are in rural areas. So, you know, having teleservices was important anyway, and we had been moving in that direction, you know, through our 1115 waivers and some other initiatives. So having that infrastructure already in place really positioned us in a really good spot when the pandemic hit. You know, while there were some things that we had to relax with our providers, they pretty much had the equipment that was necessary to engage with the individuals that they were serving. The other thing, Brian, I think was important for us, and this, I have to give credit again to our Texas legislature, we do not have wait lists for our outpatient services through our local mental health authorities. That's major. As I mentioned earlier, when people need services and they're ready to get treatment, the best time is for them to get that treatment right at that time. If services are backed up and there's long waiting lists, they're less likely to get that treatment that they know. And through our data, it shows that the longer a person goes waiting, the more likely they're going to end up in a hospital or an ER. So the fact that, you know, you just think about all of those things together worked in our favor. No wait list, infrastructure for crisis services across the entire state, adequate technology, and of course, having the right type of staff available to do the work.
Thank you, Sonia. David or Mike, do you want to make a comment regarding COVID-19 lessons learned and perhaps specifically also addressing technology?
You go, David. I really don't have anything current.
I don't have much to add to Sonia's comments, Brian, but what we did see during the first weeks of March is we have 7 Medicaid health plans that work with Arizona's Access program, and all of them were urgently working with us and the other providers of crisis receiving facilities in Phoenix to ensure our business continuity plans and that we would indeed continue to serve individuals. Once you develop these systems, then your law enforcement and hospitals depend on them heavily. So in Arizona, we were concerned. We were seeing a surge and still are seeing a surge on our hospitals and emergency departments and ICU care. But they're used to about 23,000 times a year. Law enforcement is engaging someone in a mental health crisis and bypassing those EDs. They come to us directly. So the health plans were very concerned about the cost increases and the outcomes of if the crisis system didn't hold. And it was a lot more challenging than I expected. In order to, you know, we had tents, I still do, with the Arizona heat, it's challenging, but tents set up to triage at the outset so that individuals who potentially have COVID-19 are in a separate unit from the individuals who do not, and ensuring that our staff, and in those early days, when people were just mini staff dealing with crippling fear around this, we redeployed our staffing from our outpatient sites. All of the outpatient and supportive services, as Sonia mentioned, went to telehealth and virtual, and we redeployed anyone under 65 to our crisis front line. Expecting that we could stand on our head, we could do that for 6 weeks, 8 weeks if necessary. And of course, that was months ago. So it's become it's just reinforced how important these services are to the community safety net.
Okay, thank you. We have a question. Can anyone, what about transportation? Please comment on transportation barriers, successes, especially for rural communities.
So Brian, the comment that I would make on that is, again, even before COVID, we had been moving to looking at technology as a solution in terms of, you know, still being able to connect with individuals, whether we're doing an assessment on that person or providing ongoing services and supports. You know, during COVID, we've seen a 300% increase in the use of audio only and 115% increase in the use of, you know, teleservices, whether, you know, a doctor. So I would say that was the number one thing that we've done in Texas to address some of the transportation challenges. It really is a challenge out in some of those rural areas in terms of getting, adequate transportation. The other piece is, having our mobile teams and the fact that our services are mobile. So we can actually go to individuals in terms of just general outpatient services as well.
Thank you. David or Mike?
Anything
Nothing from me.
Mike?
No, I don't have anything.
David?
Nothing to add. The challenge right now, and John Snook and his group have looked at the impact on law enforcement. So, I referenced up front that about 10% of police calls are for mental health and suicide crisis. And what happens is individuals are forced with this conundrum. Police either have to take someone to an emergency department for medical clearance, where they may have to wait hours and hours and hours. They call it wall time, where they're expected to be available to attend and potentially to transport. And the reality of the amount of miles they have to travel is what pushes on an unknown data point for us right now, is how frequently do law enforcement in fact say, I'm not going to deal with all that. I'm simply going to book them on a nuisance crime into the local jail, which I can do in 30, 45 minutes, an hour maybe, and not have to be held up for hours and hours and hours. And we're seeing states, again, tackle these transportation, not emergency transportation, and emergency mental health crisis transportation in a variety of ways. Mobile crisis can be an engaged resource in that, depending on how you pull it off, but it is an issue that has to be addressed. It's a core component. One of the things we're seeing now is crisis now, as it begins to move in Phoenix. We really don't have law enforcement doing the wall time thing. They just go directly to one of 3 geographically placed crisis receiving facilities, of which we at RI operate one of those 3. The other 2 are operated by 2 different companies. But as we've begun to look into fire and EMS, the EMS they just won't. They're going to take them to the hospital first, and some of that is culture, and some of that is their view of billing and credentialing and regulation and protocol and policy. And so we're starting to battle through those issues in the same way. We want to, again, between mobile and our crisis receiving facilities, we really don't have, unless the law enforcement is coming on someone who's unconscious or clearly bleeding, has an obvious medical issue that warrants immediate attention. They're bringing them either to our mobile crisis teams or our crisis receiving facilities. We're not doing any of that. And these are ours is in the West Valley. There's one in Central Phoenix. There's one in the East Valley. So the ease for law enforcement to bring people, drop them off, and in 5 minutes to be back on the street. So just to be super clear, when there is a medical situation law enforcement has not identified, we're the ones dealing with that, not the police officer, because they're all already back on the street.
Okay. Thank you. What about kids? Crisis services for children and adolescents. We've heard a number of complaints where parents say they call a local program. The local program says take the kid to the emergency room. The default still seems to be 911 or emergency room. Any thoughts on kids programming for crisis services?
So,
go ahead, Sonia.
So in Texas, our crisis service array that I mentioned also is available for kids as well. So we don't distinguish that it's just for, it's not just for adults. The other thing I want to mention, in Texas, this last legislative session, we had gotten approval to do a few things that I think really enhance the service delivery system for children and access to care. One of the things that we recognize is that a number of people show up or present with their primary care doctor when they're experiencing a mental health condition. That's sometimes the first place that a parent might go. A lot of times those doctors may need some additional help and support So we've created a line that those physicians could actually call into and get mental health guidance and support when they show up. And the program is just getting started, but we're very, very excited about the opportunities that, you know, that type of resource will present in terms of kids getting connected with services a lot sooner and hopefully mitigating some of their challenges. The other thing that we're doing is that we're enhancing our residents, doctors that are going to be available to provide more services through a partnership with our state-funded universities and our local mental health authorities. That means that there's going to be more services online available immediately for children when they do show up and need community support. Again, I just think early engagement of people, whether it's a kid or an adult, is very, very critical. And then we also have a number of other types of services in Texas that have been tremendous in terms of dealing with at-risk youth. We have a waiver, 1115 waiver, where we serve youth through that program that have been unsuccessful in traditional outpatient settings. That program has been tremendous in terms of having that as a resource that's directly focused on serving kids.
David, do you have anything to add?
Yeah, Brian, and I might actually just roll up. There's some questions in the comments about rural areas into this question about children. Prior to around 2010, I think the common view was that it was the issues with children, the issues with rural areas meant that the crisis now approach was really restricted to adults and metropolitan areas. And, Doug was referencing the work in Utah that he's doing, looking at Arizona and Georgia. Those were the two dominant states that inspired the work that Mike and I did in Crisis Now. And Georgia in 2010, and part of it was related to the Department of Justice and Olmstead and CRIPA consent decrees. But they were the first state that I'm aware of to roll out community-based mobile crisis to all 159 counties, every single county of the state, all the rural areas. And they since have integrated their mobile teams that they are responding to both adults, children, frankly, both in Arizona and Georgia. It's any age, toddlers. You've got social services referrals of very young kids sometimes, and mobile crisis will do any age. In Georgia, they do not only mental health, substance use, and suicide crisis, but they do IDD. It's all rolled into one blended sort of an approach that goes across. So in terms of call center hubs in the Crisis Now model, that's the common approach, is all ages with specific protocols around parental involvement, et cetera. Mobile crisis goes to all ages. It's really the facility crisis response that we're not yet seeing the emergence of the child and adolescent services. So here in Phoenix, that Crisis Now approach is there for an adult, regardless of where you're at across the county. But children frequently face the same kinds of psychiatric boarding, adolescents that we see in other parts of the country. And that's one that, we're going to have to battle through as we move forward.
Okay, thank you. There was a question also in the chat box about a particular database for call centers. Any recommendations for a dashboard? Any thoughts on that?
Brian, I'll have to get back with you. I know that our different LMHAs use different systems. But I know that those systems there are some systems that exist that are automated that will let you know how long it took for the call to be answered and provide, almost like a printout of reporting and data. And because there's different systems that are utilized, I'd like to get back with you on that.
I'll make a comment that David probably can't make. And as you know, Brian, I was working with a team in Baltimore, which is putting together a regional crisis system, and they wanted to look at software to run it, and looked around quite a bit and ended up with an intention to buy the system or lease it or rent it that GCal uses in Georgia. So having said that, David, can you just say a little bit about that system?
Well, so what we've done over the last several years, Mike, is work to implement the exact framework that you and I and the task force with the Action Alliance put together, that 5 fundamental electronic elements are needed to make the care traffic control approach work. And at the end of the day, it's not about technology. It's about holding the hand of that individual in crisis and ensuring you've got them through that chain of coordination and care. But given the sophistication of mobile teams and electronic bed inventory and crisis beds, it's just impossible to do in the old Post-it note, Excel sheet. We've had teams that use clothespins to track mobile crisis response. So you just have to use the technologies in order to do that. And 5 fundamental elements that we think are needed. The equivalent of when you see the planes on the radar, intensive service referral tracking. Those individuals that urgent and emergency needs have to be tracked through the system so that they don't get lost. They don't fall through the cracks. You're ensuring that through that, if they're in an ED, that we're mapping through till they get coordinated through. Mobile crisis dispatch that's GPS enabled. Think Uber for your mobile crisis teams, because if you're going to have a quick response that the family and law enforcement is going to say that works, we don't need to call 911, then you've got to be there as quickly as possible. Electronic bed inventories. We referenced the work that Ted and others are doing around the SAMHSA bed inventory. The funding that was out there really comes from initiative in Virginia that was started after Senator Creed Deed's son died of suicide. So those specific components, electronic scheduling, GPS-enabled mobile crisis dispatch, electronic bed inventory, and then the dashboards that show the outcomes in real time, to the point that Sonia was making. Those utilities are all part of that care traffic control system. And I appreciate Mike referencing the one that Behavioral Health Link has developed, but clearly there are others also getting into this space. RI actually uses some of that the bed track component of BHL's inventory. But in Delaware, we actually use another company's program that's funded through the Delaware Department of Mental Health and Substance Use, which is, now I'm blanking on is it Open Beds, Brian?
No, it's called DTRAN, the Delaware Treatment and Referral Network.
Okay.
Powered by Open Beds, yes.
Powered by Open Beds, okay.
But it is a bi-directional referral system, and we were able to put it into most of all the emergency rooms, and in COVID, it proved to be a really important tool to make sure that we were able to immediately get people placed within sometimes as little as 30 minutes.
The power of these tools, when you can actually see we're not talking about self-report on a website of how many beds are open, but it's actually an inventory system which tracks ins and outs. Like, again, we're talking about bringing technologies and systems over that are used every day in other industries around inventory management. You begin to get an efficiency gain that's it's actually hard to fathom how much impact you can make simply by beginning to monitor it in real time.
Thank you. Thank you, Elizabeth, and thank you, David. One of the questions that's come up is funding, especially during this time when there's obviously a decrease in revenue to states all across the country, or decrease in revenue for local and states. Any thoughts on how states can plan? A couple of things. One is, how do they establish the needs of their system, what the costs would be, and then how do they convince the budget people, whether it's in the executive branch or the legislature, that this is a good way to spend money?
And I'll speak about that at a macro level, and then David and Sonia may have comments as well. I made a comment on this in the chat box. Almost nobody has done this cut from whole cloth, at one time. Almost everybody has built this incrementally. I remember being in the audience a gazillion years ago when Gwen Skinner from Georgia came and shared with us the way that Georgia had created what became a GCAL, just because they were so overwhelmed with Katrina and had no way to measure where people were. It sort of blew my mind to have this as a statewide system, but it's continued to grow. And mobile crisis was weak and scattered and not present in all county, and then that was added to. The most robust approach to funding is no doubt Arizona's, and Arizona is unique in that it was the last state in the country to do Medicaid, but did it big bang when they did it under an 1115 waiver, and so Arizona funds basically the whole system out of Medicaid, including the call centers under the 1115 waiver. The facility development costs are something else, and I won't get into that. I will say that funding the call center is more likely to lean on the ingenuity and creativity of the state behavioral health agency than anybody else, a state or local. It's hard to do that any other way than writing a check. Although, as David pointed out, the 988 dialogue may begin to change that a little bit. It will change it. And if we can get a little bit of money out of Congress for the block grant, states are going to have to make strategic decisions about where to put that relatively small amount of money. There's no doubt that Medicaid and indeed other payers should cover mobile visits as well as crisis facilities. But since they do that on a sort of a per call or a per bed or a per chair basis, the basic infrastructure of it has got to be created. So I don't know, Sonia, how have you done that mostly in Texas?
So in Texas, we're first of all, we're not an expansion state. Our legislature has truly invested in the crisis services. So, you know, there's a little over $80 million that goes to fund, you know, well, that was back in 2007. Today, I know that number is higher. And then in addition to that, those dollars, there's been these, you know, 3 different grant programs that have come online that total over $100 million. And those kind of, you know, play a role as well. The one thing that I'm going to say that I think has also been beneficial. So like I told you about the unique geography in Texas, 254 counties, 70% of them are rural. Well, before I came to state government, in 2014, I actually was the chief of mental health services at Tarrant, which is the 2nd largest county in Texas, and ran some of these programs we're talking about. And so one of the things that we had started doing is partnering, because back then it took about $200,000 at minimum to set up a 24-hour call center and to have the appropriate staff. Well, if you can imagine, you know, being a very small rural area and not getting that many calls, it's not really cost benefit to, you know, set up a $200,000 call center. But it is beneficial for those that get a lot of volume to partner with others. And so we ended up, you know, partnering with about a half a dozen other local authorities. And so they got their needs met. And they were able to capitalize on the infrastructure. So that actually brought the cost down. So if everybody tries to do the same thing, it's not cost effective. But if you look at maximizing where you have that infrastructure, and it of course requires some training. I mean, we had to do a lot of cross training of the staff so that they could become familiar with resources in those contiguous counties. We did the same thing with mobile crisis outreach teams. If there were contiguous counties that were close by, rather than a small LMHA trying to develop those services, they partnered with one that had an infrastructure that was already in place.
David, do you have anything to add?
Yeah, well, first, I think Sonia's comments on the specialization are really important. But if the question is, how do we begin to make this case with our local legislature and other community leaders? Law enforcement and hospitals are your primary partners. Most states are experiencing psychiatric boarding, and most states have law enforcement traveling many hours and spending a lot of time in hospital ED. So those are key sort of allies. But the tools that we've put forth as the primary ones, and they're again on the crisisnow.com website, along with the NASMHPD and SAMHSA resources, is a community-based forecasting calculator where you put in your population size and then what are the current resources that you have in place already. What mobile crisis or crisis receiving facility services do you have? And then it's not a super complex formula, but there are a few elements you've got to have in there. You've got to know the occupancy, the length of stay. You've got to have a sense of the throughput, the readmission rates, some just basic elements that give you a sense of how that works for you and what it creates for you. And then you can see the cost savings by virtue of deploying some of these Crisis Now components. Look, I'm here in Phoenix, Arizona. We have about 4.5 million in population for Maricopa County, Phoenix. And it's a $100 million annual investment in those three fundamental crisis building blocks that we've been talking about. A lot of that comes from Medicaid, but I can guarantee you we're not spending that money in Arizona unless it has a clear-cut cost benefit of doing it. The Arizona Medicaid Authority is ACCESS, or the Arizona Healthcare Cost Containment System, and it's really been focused on how do we achieve the best outcome in a safe way in the most efficient and effective manner possible. And when we put together the calculator, one of the things we were really focused on is how does that cost savings occur, which is roughly $2 savings for every $1 in investment is what Tom Betlock and the Arizona Medicaid Authority came up with as we were evaluating this, Brian, back in 2017, when you challenged us to look at the business case for this. But one of the underlying components of this is if you look at the individuals who we're calling core community crisis. And core community crisis are those in your communities, not who call a crisis line or talk to a pastor or a coach or a friend, but those who land up in the back of a police car in an emergency department, or if you have real mobile crisis, it could be mobile crisis. One of those three primary components. What we've done is found that regardless of what your community looks like, it's approximately 200 persons per 100,000 population on a monthly basis. So that's 8,000 plus a month here in Phoenix that are hitting one of those three. And then what we did was we looked at those 8,000 and evaluated their clinical acuity. Our systems are built on this sort of light switch sort of approach that they all need acute care or they could get by with outpatient or follow-up. The reality is more than 80% of those individuals are locus 3, 4, and 5. The assessment that you would do does not suggest they need either outpatient or acute care. They could be served with mobile crisis or facility-based 23-hour temporary observation and treatment or short-term crisis hospitalization. And that's what really drives. So as you begin to use something like that calculator as a template, it establishes a pretty powerful data element for you to get into the dialogue. And then I would just pair it with the evaluation. And again, Brian, we've put on the website resources around the savings in psychiatric boarding and wall time for hospitals and law enforcement. Something I think was important, again, prior to 2020, but leaning in now with everything we've got going on.
Thank you. And our time is up, but I want to thank Sonia, David, Mike. It's been a great panel. Thank you, everyone.